Boom. Good evening, good evening, good evening. Let's wait for some people to come on here. Hello. And good. All right. Let's go here. So let's see if anybody shows up, and then we'll I don't know, we'll chat for a little bit, and then I'll let you guys go. Okay. So I thought that I'm trying to be consistent here, because I said that I would do some more live streams. I'm going to try and do one of these a month, and then I'll chat with you guys about whatever you want to talk about, and you guys can put your any questions that you have in the chat, and we'll talk about that. Also, I want to tell you guys that a lot of people have suggested that I do a Patreon live stream. So I'm going to, or not a Patreon live stream, but a Patreon, pardon me. So I'm going to set that up, and I'm going to do something different on there because I spend some of my time as an educator. So I'm not only just doing what I do as a surgeon on a day-to-day basis, but I'm also spending some of my time teaching other students, or teaching medical students and teaching residents how to do orthopedic surgery. So I want to spend some time on my Patreon, potentially doing a little bit of that, and having, I don't know, maybe monthly group sessions where we'll do it over Zoom or Google Meet or whatever. And where instead of me just talking about random shit, I'm going to talk to you guys about the things that you want to know about with respect to your education. If you guys are students anywhere in medicine, orthopedics, or paramedical fields, and also any questions that you guys have might have about what I'm doing on social media and how you might go about replicating that kind of stuff, or if you want to know how you might go about building your channel and stuff. So I think I'm going to do that on Patreon. And then people can sign up for that, and we'll do monthly sessions where we can chat about all that stuff. But having said that, let me go through some of these comments on the recent videos. And while I'm at it, just let me know your thoughts. If any of you guys have watched some of the last videos, or the videos I've done this last month. So I've done the gorilla, 100 men versus a gorilla. The science behind Ashton Hall's viral morning routine. I tried to do what I thought was a balanced analysis of issues that anti-vaxxers raise, and then also the Primaris Space Marines. So let me know what you guys think about that stuff, and if you guys have any ideas for content moving forward over the next little bit, then put that up. Was funny. Thank you. So the interesting thing about that, it's funny when that came up as a topic on the internet. In my house, my boys are always talking about things like this, or not now, but when they were younger. And for those of you who don't know, my two sons are best friends with Dustin from Just Dustin. And so the three of those boys were always in the house talking about these kinds of things. So when I saw that come up on the internet, I had to jump on that and give my medical take on that. But it's very, very interesting that, and I tried, I know it's a crazy idea, but I did try to give it some actual real medical thought and critical analysis as to what I thought would happen. Just Suchi, absolutely love the anti-vax video, and I have the 100 girls. Okay, thanks. I appreciate the support. Listen, I'm going to tell you guys something. So I lost probably a bunch of subscribers after I did that anti-vax, and also the measles videos talking about those things. And a lot of people were upset with me. And if you look at my demographics, just because of the things I talk about injuries, I talk about firearms, and a lot of things that kind of, in terms of political spectrum, those things probably skew a little bit to the right. And please keep in mind that in Canada, even though I would be what's called a conservative in Canada, I'm still left of, like, our conservatives in Canada are left of what is the Democrats in the United States. So we are still way more liberal than what you are in the States. And I knew that when I did that, people might be upset with it. And I'm not trying to do anything. I'm not trying to be overtly political. I'm just trying to talk about what I think is pertinent to what I do in medicine. And so I liked doing that video because I thought it was important. It was an important concept to talk about, and I did it even though I knew that some people were not going to like it, and some people would probably leave the channel. So it is what it is. I'm not trying to be political with that. I'm just trying to be. I'm trying to provide information as I know it, based in science, and so that's my viewpoint. And if people want to make it political, then so be it. So let me see here. GP Ranger, your everyday explanations help me remember and retain the information for my anatomy class. Man, I'm glad to hear that. For those of you who don't know, I used to be a high school teacher for a couple of years before I started medicine. So I try to make everything as approachable and as understandable as I can. And so when I hear stuff like that, then that lets me know that, yeah, I'm doing the right thing, and I'm hitting where I should be. And I want to make everything. When patients come to see me, I don't want any patient to walk out of my office and not understand what I was talking about. So I do stuff like this, even though I'm doing this on YouTube. I bring in concepts like this when I talk to my patients, because I want to make sure that they understand what I'm talking about. So that gives me great joy to know that the stuff that I do helps you to understand. What do we think about 3D printed organoids? 3D printed organoids from clone tissue. Listen, I think that's amazing technology, and I think that is the first step of what we're going to need to be able to prolong human life. And we have a lot of issues with transplanted organs because of rejection, which is a result of the immune system. And so for people who need transplants, we have to put them on immunosuppressants to tamp down their immune system, so the immune system doesn't recognize that the transplanted organ does not belong to them. So the ultimate holy grail would be to create 3D print organs at will. And whatever you need a new heart, print it out and transplant or put that into somebody. But before we're able to do that, we first need to be able to master the development of these tissues, and then we need to be able to 3D print those tissues. So we've just sort of started that and started that process of learning how to do that, and I think that's amazing technology. And I'm looking forward to a time. I'm hoping. So I'm 55 now, and I'm hoping that within my lifetime, I'll be able to see, instead of me putting in a total knee replacement, which is artificial. Do I have one here? No, I don't have. I got a hip replacement here, but I don't have a knee replacement. But I'm hoping that within my lifetime, I'm going to see the time when, instead of me putting in metal prosthesis, so metal distal femur, metal proximal tibia, and a plastic insert, that I will live to see the time when we are able to basically take a 3D scan of your joint, 3D map it, and then using biologic components, we will then be able to 3D print out the structure of your knee or your hip or whatever, so that we can transplant that in. And obviously that's very complex, and it's going to need to have not only the skeleton, but also the cartilage, the surrounding ligaments, the blood vessels, and the neurological structures. So I am hoping that I am going to live long enough to see that. But I do think, if we don't blow ourselves up first, that is something that will certainly be coming in the future. And I think that technology is going to be like amazing. Connects Kid, I'm finally employed again after 3 years due to lumbar injury. Yeah, geez. Listen, man, Ehlers-Danlos is bad news. And other than stretches and practice safe movement, do you have any suggestions to stay healthy? I do, actually. So I'm going to put in the chat here. So in the chat, I put the website for some people that I interviewed on my podcast. And I think it's on the podcast on this channel. So if you look them up, Andrew and Kate, and they run whealth.com, and their site specializes in pain relief, exercises, and training for people who have chronic pain, but in specific Ehlers-Danlos. So I've collaborated with them in the past, and they have a lot of great information. And so if you're looking for stuff to do that is safe for you and that's going to be beneficial for you, then check them out. Please do that. Philip Denick, I've been practicing karate and judo for 30 years plus, and gym for the last 10. Recently, I've been diagnosed with a golfer's elbow in both arms. Any specific suggestions for recovery? Yes, sir, Philip Denick. So obviously with golfer's elbow, this is from you doing a lot of grasping like this. And so you get pain on the inside part of your elbow. And that's because if you look at your forearm, the flexor pronator group, which is a group of muscles that comes like this, that turns your hand over and it grasps like this, that group of muscles all lays on the inside part of your arm here. So, and when you use it repetitively and not give it time to rest, or you overload it with too much work, or you don't do enough stretching, then you get tendonitis of the elbow. So, and especially with judo, with all the grasping that you're doing, you need to counteract that with a lot of stretching. So there's two things that I would say for you. Well, three things. So number one, you need to change the amount of load that you're putting on the flexor pronator group. And so that means you may need to decrease the quantity of what you're doing, or change the timing of it in the week so that you give enough time for rest in between each session. So that's number one. Number two, you also need to incorporate stretching after you're doing those activities. So you're doing this all the time, so you have to do the opposite of that. So you need to extend the wrist, and you need to work on supination of the wrist, put the hand upright to stretch out this inside part of the elbow. And lastly, you need to incorporate regular exercises where you are doing eccentric loading. So basically, where you are instead of doing this, which is what you're normally doing, you need to be doing this, but under load, and allowing these, the tendons that are associated at the attachment of these muscles to lengthen under load, and which is known as an eccentric contraction, where you're trying to contract the muscle, but the muscle is getting longer, because that's been shown to be beneficial for tendonitis. But let me put something in the chat here. So Philip, let me put this in the chat here. So if you search on YouTube and you just do this right here, gymnastic wrist prep exercises, and especially from GMB Fitness, another guy I've talked to, that's for you. So I put that in the chat there, gymnastic wrist prep exercises, GMB. So check that out. Okay. Do you think about 3D printing? Yeah. Finally, okay. I found your YouTube channel recently, started to binge watch your content. Well, thank you very much. I appreciate that, Carlton. Ryan, Dr. Chris, I have a very unique diagnosis that causes osteoarthritis without manual damage or use of the joint. It took a long time to figure out it was psoriatic. Yeah, well, that sucks, man. So some people have, so psoriatic arthritis, for people who don't know, is an autoimmune condition. And so psoriasis is an autoimmune condition that affects your skin. And sometimes you can have arthritic involvement of the joints associated with that, and that will cause slow stiffening and destruction of the joints over time. So that sucks. But the great thing about that is that, you know, there are medications you can take to sort of tamp that, again, to tamp down, bring down your immune system, so your immune system stops attacking you. Yeah, that's not fun. Certainly you get, you can have a lot of joint pain associated with that. The Ruined Drone says, what happens when with these kinds of future tech, like 3D printed hearts, we can extend the physical body longer than we can possibly extend the brain and mental essence of a person? Well, listen, man, I'm not sure that is going to happen. Sure, you can extend the parts, but as long as you can keep the brain healthy, then I don't see any reason why you can't keep extending these and reprinting these parts for as long as you can, as long as the body will accept it, because your mental capacity and the essence of a human being is a function of the health of your brain. And as long as we can keep the brain in good functional condition, then I don't think it should be a problem. Obviously, as with any other body part, over our lifetimes, your brain will degenerate, because either it will accumulate small microscopic damage, or it could have large scale damage from injuries that you've had. You may have damage that occurs as a result of decreased oxygenation. If you have atherosclerosis inside of your arteries that are feeding your brain, and so your brain function will decrease as a result of all those things. But if we have the technology to print out body parts and organs, I'm going to assume that we also will have the ability to make sure that the brain is maintained at its optimal state. So I think if those two things are going to go together, if you can end up keeping the body in its optimal condition by doing this, like by 3D printing parts and replacing old parts with new parts, then I think you're going to be golden. Now, and the one caveat is that if your DNA is damaged over time as a result of inefficient copying, as a result of oxidation or exposure to radiation, then that's something else that you have to consider, because you may be able to keep the tissues in great condition, but if the DNA has been compromised, then you may end up with problems down the line. But overall, I think if you can reprint organs, you're probably going to be able to figure out ways, to keep the brain in good shape. So that's what I would say. Yes, you are right, Jared. Always remember, rehab is a lifelong event, not a one and done activity. Killa Jam, is ChatGPT a good doctor? Yo, listen, Killa, I did a video last year, maybe the year before, on ChatGPT. I can't remember what version I did. Maybe it was ChatGPT 3.0, whatever. But I asked it a bunch of orthopedic questions to see just how good it was. And obviously, it's a large language model, so it has all the information that is present on the internet up to a given point in time around a topic. And it's going to synthesize, it's going to go through all that information, pick out sort of the most widely accepted response. So for most things, it will probably keep you pretty safe. It's not always going to be right. And it's once you start to get into situations that are more complex or more nuanced, it's not able to do that. It cannot really come to creative conclusions, or it can make shit up. I've seen that, but it's not going to sort of creatively come up with a solution to a particular problem. If it ain't in the literature, then it's not going to make that thing. And when I say it will make shit up, like it will fabricate, at least at that time, it would fabricate some answers. And it's not that they were a total fabrication, but they were sort of taken from parts of real answers, but they weren't the right answer in its entirety. But it won't come up, I don't think, at this point, in just with novel solutions. So will it get better at some point? Sure. What's DeepSeek? Is DeepSeek going to be a good doctor? I don't know. But apparently DeepSeek's supposed to be way better. Personally, I don't trust China with my information. So I try not to. So I've never used DeepSeek. I've used a bunch of things. I've used ChatGPT and Perplexity, and particularly Perplexity Pro, because it gives you all its references. But yeah, I don't know. I don't think it's a great doctor, but the thing that I like about AI responses is that you could look at Google and it just spits out information for you. Or it used to just spit out information, but it didn't really synthesize that and put it in, give you a comprehensive response that people, like the average person, could understand. So now with these tools, you get a little bit more context. So that I think is a good thing. And you can see that now with your Google searches, and they have an AI response up the top before all of the query responses that are listed down below, so that you have some context to understand the information that it's providing. So is it a good doctor? No, but it certainly can give you a reasonable background about a medical issue. I can't really take off work, but my shifts are long and I've got Baker's cysts on the back of my knees. My MRI X-ray appointment is quite a ways out. Are there any suggestions until the appointment? Just sushi. So listen, people who have Baker's cysts is quite common, and people get all excited about it. I wish that they had called it something different, because it's not really a cyst. Baker's cyst, if you look at the knee capsule, it's like a canvas bag. And when your knee doesn't like something that's going on inside, it will produce extra fluid. Extra synovial fluid, because the synovium, which is the lining of the knee, it gets inflamed. Because the bag doesn't expand, the fluid's got to go somewhere. And when you look at the knee, there's a big pouch at the back of the knee, which is just empty space. So any fluid that is produced within the knee, eventually a bunch of it goes into the back of the knee, and that's called a popliteal cyst or a Baker's cyst. And it's just a collection of fluid. And people always want us to get rid of them, and I'm like, bro, we don't need to do that. All we need to do is fix the problem that is causing your synovium to get excited, and then it'll go away on its own. So but for yourself, because you don't have a diagnosis yet, you don't know what the problem is, then I would say, if you can, and my caveat before I tell you this is that I don't, I'm not a big person. I don't try to tell people to take a lot of medication. But if you're trying to deal with this, and you're spending a lot of time on your feet and you don't know what's going on yet, then an anti-inflammatory is something that I recommend for my patients to use on a time-limited, temporary basis to help them decrease the amount of fluid that's present. And then once that popliteal cyst and the fluid inside their knee decreases, and you will know that it has decreased because, number one, you won't have the fullness behind your knee. Number two, you probably won't have the discomfort or aching. And number three, your knee flexion or knee bending should be able to improve. Once that occurs, then you need to start looking at, well, what are the things that you are doing that are causing the knee to get inflamed? And if you don't have a diagnosis, then you have to be really kind of cautious and careful, because the things that will, there are a bunch of things in the knee that can make your knee swell and be upset. But the most sort of normal things or common things are meniscus pathology. So you have a meniscal tear or meniscal damage, or you could have cartilage damage if you had an injury at some point. But usually you're going to know that because you're going to remember, oh shit, I twisted my knee when I did X, Y, or Z. So you're going to have that. Or you have just an autoimmune disease, and you have synovitis that's a function of that. So if we go back to the meniscus pathology, okay, so the meniscus is being the shock absorber. You have two of them on either side, one on either side of the knee, on the inside and the outside. If it's the meniscus, and for many people that will be the thing, you'll have some kind of meniscus problem, then the things that you want to do while you're waiting for a diagnosis and for treatment is you want to minimize what bothers the meniscus. And when you're just walking and you're walking on flat ground, the meniscus just sees force up and down. And even when you bend your knee together up to 90 degrees, you're only going to get what's called compressive forces on the meniscus. And the meniscus, even if it's damaged, can tolerate that pretty well. But once you get past 90 degree, the knee actually bends and then slides a little bit. And so that sliding is going to open up any tears that are on the meniscus and make it unhappy. So if you can avoid it, try not to bend your knee past 90 degrees until you've got a diagnosis and until you've been treated. The other thing that the meniscus doesn't like, again, because if there's a longitudinal tear through the meniscus, is when you pivot, okay? So if you got to move and turn, don't pivot on your foot. Pick your foot up, put it down, and move that way. So those are the two suggestions I give my patients who are waiting for surgery, in order to minimize what's going on. But that's what I would say about the Baker's cyst there. Okay, boom. Why, thank you, Rick. I make awesome videos. Thanks. I got an awesome team, man. And listen, I'm just trying to grow the channel and get my content out there. I think that our team has been doing some great things recently. And even though, as I said, I put out some content that some people might see as political, I think we're putting out really good information. And I think what we're doing is really educational. And I'm just hoping to grow the channel so that more people can see what we're doing, because I think it's really good. And I'm having a crap ton of fun doing it. I love to educate people. And I think that the information we're putting out is great. So Rick Foyson, when I was younger, fentanyl was not a thing, but nowadays it is. I just say no, but a lot of people don't. So videos help make better decisions. No problem, Rick. You are right, man. Fentanyl never used to be a thing. I remember when I first started my orthopedic training. So I did that in the year 2000, and we were just starting to see at that time some people who were gaining access to fentanyl, and at that time there was no sort of illicit market for the creation of fentanyl, so people didn't know how to make it from labs yet. And at that time, people were doing some crazy shit to get it. We used to have, well, they still have these, but people would have, who had chronic pain, used to have fentanyl patches, which is basically a Band-Aid, which is infused with fentanyl, and you'd put it on, and then you could wear that for 72 hours, and it would slowly release fentanyl to control whatever pain you were having. And they were primarily used for cancer patients who were having really severe pain. But anybody who had really high level pain from some kind of chronic condition, you could have this fentanyl patch. So when I just started in 2000, we were just starting to see people who were scraping out, opening up those Band-Aids and scraping out the contents and trying to distill out the fentanyl from those pads, and so that they could take it. And we were just starting to see people get some infections because they were trying to inject the fentanyl that they had got from these patches, which when you're doing all of that, none of it is sterile. So they'd be giving themselves infections from bacteria that is normally on the surface of your skin but shouldn't be living inside of you. And we're just starting to see that, but it's gone really crazy, man. And it's sad, and obviously we've talked on the channel about fentanyl, we talked about tranq, a whole bunch of different illicit compounds. And it's sad to see what is happening. And then add into that mix that now there are less resources for people who have psychiatric problems, and many of those people are out on the street looking after themselves, and they're also self-medicating, and it's just fentanyl it's very sad. Let me see. Atlas Labs is working on Eternal Life. They have $1 billion investment from Jeff Bezos. Oh, well, listen, man, we'll see what happens to them. I'm not sure that I would want to live forever. That I'm not sure. Yeah, you might really get bored. And the thing is, I'm not sure that I want to live. If I'm going to outlive everybody that means something to me, my family, my kids, my wife, my grandkids, whatever, my friends, if they are not all going to survive, and then I'm not sure that I want to do that. Number two, unless I can make sure that my body is going to be in perfect working condition, so that I can, run, be active, I can work out, train, all those things, then again, I'm not sure that I want to do that. And if my mental faculties aren't 100%, then again, I'm not sure that I want to do that. I wouldn't necessarily mind living a bit longer, because there's things in the world that I want to see, events that I want to see, and I think there are things that we are just on the cusp of, that I think would be amazing to be a part of. Such as, like, I am a space nerd, and I do think that there is life out there in out there in the universe, other than us, and I do think there is intelligent life somewhere, and I think I would love to be around when we discover that there is, and we finally realize that we are part of a larger family of beings in the universe. So that I think would be cool. So I wouldn't mind living a bit longer, but I would do it with conditions, and I don't think I'd want to live forever. Yeah, I just don't think that it would be rewarding to do that. Let me see. Zion, AIs are grateful companions for vetted elites in any given fields. Well, listen, man, I do use AI from time to time, and my editor uses it for some of the images that he uses, and I know a lot of viewers don't seem to like that, and I get it. But I've also tried the other route of paying an artist to do video or do stuff for me, and it didn't work out how I wanted, in terms of timeline and just they if you're under if you've got a timeline that you have to adhere to, it's much harder to do that with a real living creative. But having said that, I do use AIs for different purposes, with respect to researching some content, just sometimes to give me some ideas, or if I'm trying to understand something that is completely foreign to me, I've never seen it before. An AI is a great way to summarize some of that content, so that I can have sort of a good foundation, and then I can start to understand better some of the individual articles or things that we might be reading. So I think that's cool. What's the cause of a lipoma? Well, hey, Jay, so a lipoma is a benign, meaning non-cancerous lesion of fat. And it is a random thing. Anybody can get one. You can probably get one anywhere where fat will grow on your body. And for almost all of us, that means anywhere. Anywhere like the skin is separated from your muscle tissue underneath by a thin layer of fat. So you could get it pretty much anywhere. It's a for most people, it is a random thing. And it just means that in one localized area of your body, a group of fat cells didn't listen to the signals that tell them when to grow and when not to grow. So they just started to kind of grow on their own. The reason, though, that it's not cancerous is because although they're kind of growing on their own, with a lipoma, which is benign, usually they have a capsule, or all the time they'll have a capsule around them, meaning they'll have tissue outside of them that prevents that fat tumor or that fat growth from growing into something else that it shouldn't be growing into. It could put pressure on other things that are adjacent, but it won't grow into. So that's kind of the first thing. It's got a capsule around it. And then number two, usually their growth is self-limited. They will grow for a period of time and get to be a particular size, but usually they don't keep growing. If they keep growing unrestricted, then that would be a liposarcoma, and usually that's a cancerous thing. So a lipoma is benign, and it usually has a capsule, and it will grow to a certain size and then stop. So what causes it? Random thing. There are some people who have a genetic predisposition to growing these, but for most people, it's random. Is it possible to have a hairline fracture of the kneecap? And would it hurt when walking? I fell in concrete and skinned my knee 2 days ago. Today it started hurting. Thank you. So Paula, yes, it is possible to have a hairline fracture of the kneecap. It would hurt when walking. It would also hurt when you are flexing or bending the knee. And to be honest, I think it would probably hurt more when you're bending the knee, when you have a lot of compression on that of the kneecap compressing down onto the surface of the end of the femur. So it would certainly hurt. But you could also just have, because of banging directly onto your knee, you could have some quadricep and or patellar tendonitis, where those tendons insert on the kneecap, because the kneecap itself is irritable, because you've basically banged it. And for the kneecap, or for any bone for that matter, you can have a contusion of the bone, which is basically a bruise in the bone. And you won't ever see anything on x-ray, but if you look at it under MRI, you'll see a blush of fluid where you impacted that bone. And all it means is that you banged it almost hard enough to break it, but not quite. So you could have a contusion, and that would hurt like hell. And those usually last, the pain from those usually lasts around 3 to 4 months. It gets less over time, but it usually lasts around that long. But it could also just be from tension of the tendons across the knee, because you banged it and made the knee irritable. So it could be any one of those three things. If it's really bad, and when I say bad, what I mean is on a scale of 0 to 10, 10 is no pain, 0 is no pain, and 10 is the worst pain imaginable, where you're going to give me like $1,000 out of your back pocket to cut it off with a rusty butter knife. Yeah, that's 10. If you have pain that is sort of 8, 9, 10 when you're walking or when you're bending it, you should go get an x-ray, because you might have a patellar, occult patellar fracture or a hairline fracture. And the thing is, that can be treated non-operatively, right? Like if we put you in a knee immobilizer to protect it while it's healing, and we protect your weight bearing for 6 weeks, you can treat that non-operatively. What you can't treat non-operatively is if you have a patellar fracture and it pulls apart, and then we have to fixate the patella, then you bought yourself an operation. So if you have the ability to, I would just go get it x-rayed if it's causing you that much difficulty. Let me see. I love learning from you. Very educational. Thank you, Jay. Raul asks, is neck thickening exercise a good option, or does it compromise with the help of atlas axis, anterior posterior longitudinals for the meniscus between vertebral body? Well, it's like any kind of strengthening is a good thing. And so if you want to do neck exercises, I think that's a great thing to support your neck and provide strength to the structures that support your head. And that's important. Like if you're going to do any contact sport, rugby, football, or even hockey, or you're going to do wrestling, any type of wrestling, martial art, boxing, jiu-jitsu, taekwondo, MMA, whatever, then I think neck strengthening should be part of your regular training regimen, because that's something that gets something that's going to be stressed, and you want to be able to tolerate the stress that's imparted upon your head and neck. So strengthening, and I wouldn't say thickening per se, but strengthening is important. And especially if you are doing stuff where you're taking blows to the head, studies have shown that people who have stronger neck strength are less likely to get concussions than people who don't. So if you are actually getting punched in the face or punched in the head, or kicked in the head, then yeah, you should be strengthening those structures so that you minimize your chance of concussion, because concussions are not good. How can I convince one of my patients that manual therapy is just a band-aid and they're never going to get better unless they exercise, but they never want to because the manual give them temp relief? Um, that's a hard sell, man. I know that. I try to tell people this all the time. But what I say to my patients, although I'm not generally the one doing the therapy directly on them, but what I tell them is this. I say to them, when we do surgery on you, your and we immobilize you afterwards, you lose strength and you lose flexibility. So there is only one way that you are going to restore those things, and no amount of manual therapy, no amount of massage is going to make you stronger, because there are no bodybuilders that are developing strength by getting massage, right? And there are no gymnasts, there are no dancers that are getting no circus performers that are getting more flexible by just doing manual therapy. They're all spending time working at those things. So if you are weaker after an injury or surgery, you are stiffer after an injury or surgery, and you have less muscle mass after an injury or surgery, then the only way to restore those things is for you to be doing exercise. And I know it makes them feel better, and it makes them feel good, but you just have to impart upon them the fact that the problems that cause the pain are not going to go away unless they address them. And I also try and approach it from the angle of money, although this doesn't serve you as someone who's trying to earn a living from this. But I always tell patients, I'm trying to put myself out of business, man. And if they want to keep throwing away money by having us do stuff to treat their symptoms and not the problem, then that's their own prerogative. But if they'd like to save their money and not see, and only have to see myself or my team for the shortest amount of time possible, then they need to put in the work, right? Because we're not, and I tell them, I'm not about treating, I'm not about, like, when it comes to a problem, do you want to address the horse in the front that is leading, or do you want to address the cart afterwards? I'm not in the business of treating the cart, man. I could give a rat's ass about the cart. And it's not to say that I don't care about patients' symptoms. I do, but to me, the symptom is just a message, right? That means nothing to me, because if I get rid of the problem, then they don't have the symptoms, right? So I don't pay attention to the symptoms. The symptoms is a red herring. But the symptom is a message to me that there is a problem. Then, using my my education and my skills and my diagnostic acumen and tests, I can then learn what is the cause of that problem, and then I can address that. So that's what I tell people. It doesn't work for everybody. Some people are babies, man, and they just want you to hold their hand all the time. And that's a little bit from the viewpoint of somebody who went into business of trying to fix people. That's frustrating. But that is the way some people are. But I have a reputation in my city. So in my city, I'm a city of 1 million. And there are about 50 orthopedic surgeons in my city. And I am well known for being the person who is like, I'm going to be the one that's going to put you to work. And I want you to work. And all the physiotherapists I employ physiotherapists because I have a rehab clinic, but all the ones that are not employed by me know about me, and they know what I believe. And if they end up treating my patients, they know that I don't want any of that shit. I don't want massage. I don't want manual therapy. I don't want passive modalities, because I just think as you said, those things are all Band-Aids, man. And I'm not in the business of putting on Band-Aids. I'm in the business of fixing shit. So that's what I try to be like. Let me see, where are we here? Is it possible to have a hairline fracture? Oh, yeah. I got that one. Sorry. Oh, speaking of wrist pain, discuss management of gamer's thumb or de Quervain's tenosynovitis. I see a lot of new patients with this issue. So listen, I had this myself from doing a lot of texting on my phone for a while. But anyway, so de Quervain's tenosynovitis is tendonitis, inflammation of the tendon sheath. Oh my God, I can't see here. Of the first dorsal compartment of the wrist, and so this is the compartment that does this, right? So if you're bending your thumb up a lot, right, because you're grasping things, you're going to grasp things, or if you're doing a lot of texting, or if you are playing a lot of video games, then this is something that you're going to be familiar with, and it hurts like a son of a gun. And you'll often have swelling along that first this thumb side aspect of the wrist on the dorsum, so on the back side here, and that's because it's a repetitive strain injury. So meaning you are doing something frequently, and you are not providing enough time for rest for the involved muscle group, and you're asking that muscle group to do something which it is ill prepared for, either because you're not giving it enough rest, you are too weak to do that thing. And obviously for texting and video games, that it's not really a weakness thing, it's just too much use. So you need to spend time to address the problem. So number one, the first thing is activity modification. And I don't want to say rest per se, but activity modification does incorporate rest. And it also means changing what you're doing. So when you have a repetitive stress injury like this that causes a tendonitis or a tenosynovitis, you're not allowing that tendon tissue to recover. And the thing that people have to remember is that connective tissue like tendons and ligaments, they do not have the same blood supply and therefore the same rate of metabolism as do other tissues, meaning the rate at which those tissues recover and turn over. So bone and muscle, if you look at their ability to recover after injury, usually we're talking a timeline of about 6 to 8 weeks, and those things can get better. The rate of metabolism, the speed at which turnover occurs inside of ligamentous and tendon tissue, is about 1/9 that of bone and muscle. Meaning, if it takes approximately 6 weeks for a muscle or a bone to recover, so at 6 weeks, we're talking 42 days. It's going to take almost a year for tendon tissue, ligamentous tissue to likewise recover after injury. So a major part of the management of these problems is activity modification. So if you are doing something and the volume is too much for that tissue to handle, then you need to change that. And you either need to decrease the volume, you need to decrease the frequency at which you're doing that thing, decrease the number of reps, provide more time for rest, and or things that I talked about earlier where you have to incorporate stretching time and especially eccentric loading of that tissue. You need to incorporate those things into your recovery. And also, these types of injuries often occur at muscles that are too weak for the task that you're asking them. And this is not something that requires a lot of strength, but if you're doing it repeatedly and not allowing the muscle to recover, then it is almost like a strength issue. So part of the management incorporates all those things: activity modification and strengthening of the tissue, eccentric loading and stretching, so that you can lengthen that tissue, which is short and is generally under a lot of contractile tension. And that's basically how I manage that. And usually when I have patients who have it, I will put them in a thumb spica splint, so a wrist splint that keeps your hand in this, your thumb in this position, so that the thumb is extended. And it's held in that position, so that we take the tension off. So you're, by holding the thumb up, it's short, the tendon is shortened and you're taking tension off of it. So that allows them to rest it, and they can go about their day using that splint. And then they can take it off to do their exercises, to wash, bathe, all that kind of stuff. So I usually rest them for about 6 weeks. For really, really difficult cases, I'll give them some anti-inflammatories. So you can use over-the-counter stuff, which is ibuprofen, which is Advil, or Motrin in the United States, or Aleve, which is naproxen, which is a stronger anti-inflammatory, but it's harder on your stomach. Sometimes I'll prescribe them Celebrex to use. And in really, really intractable cases where it's not getting better over a long period of time, I will inject cortisone directly into that first dorsal compartment there. Although I try not to do that, because cortisone is not, it's great anti-inflammatory, but it does evil things for your tendons and for your cartilage. So I don't like to use that. But I do use it sometimes for some people who are really, really difficult. So I would do all of those things, all the non-invasive things first: activity modification, eccentric loading, thumb spica splint, rest 6 weeks, and then start to incorporate gentle range of motion, eccentric loading, and strengthening. And then also activity modification, tailor what you're doing. And change something about the volume or the frequency, so that it's not, you're not putting the same demands on your hand. Let me see here. Is there any cure for it? I don't know what you were asking about there, Jay. Sorry. No problem, just sushi. So should enchondroma of D5 little finger, middle phalanx be curetaged and filled with bone graft for 30-year-old male patient? So Raul, depends. If it's not sore and it's not expansile enchondroma, meaning that you don't have a huge big bump there, then I wouldn't necessarily do anything about it. I would just monitor it, because an enchondroma can change in size, but generally speaking, for most people, they are pretty stable. And I have lots of patients who have enchondromas, and I sort of monitor them. And when I first see those people, because I'm seeing them for the first time, I'll usually monitor it more closely. So if it looks really big, or if the edges are really frail, it looks like it might break, then I might x-ray them sort of every 3 months for the first little bit. But if it hasn't changed over a 3-month period of time, then I'll go to 6 months. And if it hasn't changed over a 6-month period of time, then I'll go to a year. And if I see them a few times, once or twice at a year, and it hasn't changed, I'm going to stop imaging it, and I'm not doing anything about it. I am only doing something about it if it is very painful, if it looks like it's going to fracture imminently, then I'm going to do something. But otherwise, nah, leave it alone. So is it super painful and is it expansile? Then maybe. Otherwise, just have them monitor it on a sort of short to intermediate term basis. Hey, I just had shoulder surgery. Oh, listen, hey, Julian, I did 4 today. I did 3 rotator cuffs and anterior stabilization. I'm pretty sure I tore it again, but the MRI came back normal 5 months post-op. It feels unstable, and it didn't before surgery. All he did was tenodesis and anterior labor. Well, so if you had a anterior labrum, so you had a Bankart lesion. So you've had a dislocation, your shoulder has come out and the labrum was ripped off, then it's possible for you to have a labral injury that is repaired and still have some stability post-op. Normally that wouldn't happen at 5 months. It might happen a lot later once you had been cleared to return to sport and you go back. And that can be because if you had a lot of dislocations prior to surgery, every time you have a dislocation, you get a divot in the back of the humeral head. That divot is called the Hill-Sachs lesion. And if the Hill-Sachs is small, then generally speaking, once we do the anterior labral stabilization, then that gets rid of your any further instability until you dislocate again. However, and by that I mean a traumatic dislocation. However, if you've had multiple dislocations or your first dislocation was very, very traumatic, that Hill-Sachs lesion in the back of the head, or the Hill-Sachs groove, it's basically a groove because you have the cup, then the head comes out, bangs on the edge of the cup, and so you get a crease in the back of the head. If that Hill-Sachs lesion is very, very large, or if when the head came out of the cup, it knocked off a portion of the anterior labrum, or not the labrum, pardon me, but the glenoid, so part of the cup itself. So there was a bony fragment, and either it was too small to be fixed, too brittle to be fixed, or if your surgeon didn't see there was a bony labrum, you might actually change the face of the glenoid from an oval to an inverted pear, right? So that it's very narrow at the bottom. So if you have an inverted pear-shaped labrum, glenoid, and then you have a big groove in the back of the head, even if we've repaired the labrum on the front, it's possible that when you externally rotate your arm, even though the labrum is there, you might have a situation where, because that Hill-Sachs is very large and the glenoid itself is very small at the bottom, you externally rotate and you don't even have to do anything. It just slides out, okay? And that can be problematic. In the past, and there are lots of guys now who treat that, and they'll put a piece of bone here, either the coracoid, which is a piece of bone that are part of the shoulder that is higher up than the cup. So they might take the coracoid, take it off, and re-screw it down here. So that provides some extra bone there. So that's called the Latarjet procedure. So you might do that. That's a bony procedure that we can do, but it's a non-anatomic procedure. The other thing that we can do, this is also non-anatomic, is we can do what's called a remplissage. And so what that is the capsule. So you have your head here, and around the whole shoulder joint, there's a bag. And if this is the front out here, and you have the Hill-Sachs at the back of the humeral head, then when we fix the glenoid here at the front, after that, we'll go to the back of the head back here. We'll put an anchor in that head, and then we'll sew that anchor to the capsule at the back of the joint. And the capsule is not usually attached to the back of the head. It goes around the head and attaches further down to the neck. But when we sew it to the back of the head, the way that I describe it to patients, it's like having a leash on the dog. And so you fix the labrum at the front, you go back, you fix the capsule to the back of the head, and you get that remplissage. I'll type it in the chat there so you can ask your surgeon about that. The remplissage, every time that head starts to rotate and the Hill-Sachs is almost ready to what we call engage or slip out, you got that leash, that choker chain on the back of the humeral head, and it prevents it from going out. So the remplissage is a newer, well, it's not new, but it's been around for quite a while in Europe. but it's something that people are doing more and more now here in order to prevent the head from going out the back. And the beauty of that is that we're not cutting any bone. We're not doing a non-anatomic bony procedure, because Latarjet is a good procedure for people who have really, really unstable shoulders. But if it fails, you've now removed the coracoid, and there are ligaments that are attached to that, and as well as the short head of the biceps, and you've sort of compromise the bony structure of the shoulder by doing that. So if we can avoid that, that would be great. And the remplissage is kind of a good halfway procedure. So to come back, bring it full circle, it may be possible that you had a big Hill-Sachs lesion, and that you had what's called an engaging Hill-Sachs, or you had an inverted pair glenoid, or a combination of both. And even though your labrum is repaired, the head is still subluxing, so partially coming out, or maybe completely coming out. So, but the other thing that might just be is that because you had surgery and you've been immobilized for a period of time, your muscles around the shoulder could just be quite weak, and so your general resting tone is loose or lax, and so it kind of feels like it's coming out, but it might not be. So first thing I'd be doing was working on all of your exercises and making sure that the shoulder is strong, both in the front and the back. And then I would speak to your surgeon about, whether he thinks that you have an engaging Hill-Sachs lesion, or whether I would ask questions if the glenoid was an inverted pear shape. So those are things that I would ask about. You should do Discord so we can discuss questions with you. That would be much more interactive. So, hey, Julian, I have a Discord. I just haven't gotten around to it. But I was saying earlier that I think I'm going to do a Patreon where I'm going to do it by Zoom or Google Meet, so that I can be interactive with people. I can see who I'm talking to, and we can chat about things. That might be a paid feature on Patreon. I'm not sure yet, but I'm working on getting my Patreon set up. So I think that I'm going to do it on Patreon. I might try Discord again, but man, you guys know I'm super busy, man, because I'm a full-time orthopedic surgeon. I run a business with my wife, and then I do all of this YouTube stuff. And just to find time to do all of that is really hard. So I'm trying to build my team of people who can help me with that. But, anyway, next thing, I think the next move we're making is Patreon. So Dr. Raynor, you did really good jobs on SARMs and peptides. Please get Babu Frick to accompany Baby Yoda. Yeah, listen, man. Well, so look at, I got I got my two Yodas right there, and then my other one over there. So wait, no, this one here was a gift. I did a podcast with somebody, and because he saw the other one, he gave me that one. So that's really cool. And I'm a big Star Wars fan. I haven't watched all of the new series, but I'm trying to slowly go through them. Please, let's have an episode analyzing the movie scene in Troy where Achilles defeats. Okay. Well, listen, I see, Sean, that you asked me about this before. I will. Where's my pen? I have a pen here. Okay. Troy fight scene. Troy fight scene. Okay. I've officially written it down now. So I'm going to look at that, and I'll see if it is worthy. But I will check it out. I will promise you that. I can't promise you I'm going to do a whole thing on it, but I will definitely check it out. What's the most complicated surgery you've ever done, Jay? So I can't say what's the most complicated surgery I've ever done. Most of my surgeries are not super complicated. I've had some fractures that have kind of made me given me some sphincter puckering moments. But the stuff that I'm doing, because I'm not doing super complex trauma, I'm not doing spine. I've not had stuff that's really complex. But I will tell you, the longest surgery that I was involved with was during residency, and I was on spine service at that time, and we did an 18-hour surgery on somebody who had a spinal tumor, and so we had to for that patient we did back, front, back, meaning we started the surgery with them laying flat on their belly. We operated on their back for about 6 hours. Then we temporarily closed that wound, put a dressing on, flipped that patient over, and then opened their belly with the assistance of general surgeon. We went in and then operated on their front, and then did what we had to do on the front. Then we closed back up their belly, flipped them back over, and then finished up what we had to do on their back. So that surgery took 18 hours. Yeah, it really sucked. And that patient, unfortunately, was a very complex surgery because they had spinal tumor. And to be honest, I can't remember how that patient did in the end. They survived, but I just can't remember what their neurologic function was like in their lower extremity, because the tumor was kind of like at the lower thoracic, upper lumbar spine. But yeah, that surgery was very hard. It took a lot of work. I was just the scut monkey at that time, so I'm doing mostly retracting and all that because my staff person was doing most of the surgery. But that was pretty challenging, and I got to tip my hat to the spine surgeons because they have really bad, like, spine surgery. Spinal surgery is something that people only do as a last resort, meaning that they failed all other treatments, and usually the problems that those surgeons are trying to fix are really, really hard problems to fix. And the patients don't always have great results because they've already reached the end of the road. And it's really disheartening sometimes. So, hats off to the guys that do it, the guys and girls that do it. I don't want to do it. And I just don't think I'm emotionally or mentally tough enough to deal with that. So, yeah, but that was the most difficult one. I didn't do it, but I was part of it. Do you repair shoulder labrums in people over the age of 30? Oh, hell yeah, Julian. Yeah, I do that. So I'm not when I went through my training, there was a lot of stuff that I learned where people were, my preceptor said, "Oh, we're only going to do this on people under the age of X." So ACLs, if you're 40 and under, we're only going to do them then. Labral repairs of the hip, 40 and under, that kind of stuff. I don't do that. I look at the patient, I look at the condition of their tissues, and I look at whether I think they're going to be able to do the rehab that's required, either because of personality or whatever. And if you have good tissue, minimal arthritis, and I think you're going to actually do the rehab, then I'll operate and I'll fix your labrum out, whatever. If I think it's going to be of clinical benefit to you. I'm not, if I have elderly patients that have fallen, it doesn't happen that frequently because usually older people who fall get a rotator cuff tear or a proximal humerus fracture. But I've had older people who've fallen, and I've repaired, I've done a stabilization, anterior stabilization on them. And because I knew that they were active people, they were going to do it. And likewise, at the level of the hip, I've had older patients who have hip labral tears and no arthritis, and I've fixed those people. Even, I think my oldest one is in late 60s, and most of my colleagues would not do that. But I do it just because who am I to say that they can't have it done? If they have good cartilage, labral tear, and they are people who are active and they're going to actually do the rehab, then yeah, I don't think that's a waste of resources, and I'll do it. So listen, I'm gonna answer two more of these, and then we're gonna call it an evening here because my wife is waiting to watch The Last of Us. No, what we no, sorry, Handmaid's Tale. That's what we're watching tonight. Uh, we taped The Handmaid's Tale, so we're watching the next episode. Okay. I often said healthcare should be doctor. I'm feeling okay, but how can I feel better? What we normally do is damage mitigation, not healthcare, and it's not the GP's fault. It's us. So true, man. So true. We people need to take more responsibility for what they do, man. That they need to look after themselves, and your physicians shouldn't be the people who are fixing your problems. We should be just helping to provide some guidance to help you to fix your problems. And if people were to make better choices, people, even myself, we were to make better choices, we would have less things to fix and less things to take care of. So, my goal as an orthopedic surgeon and as a sports medicine physician is to educate people, provide them with as much knowledge as they can about how to look after themselves and how to avoid coming to see me. And hopefully, at least from a musculoskeletal point of view, I can minimize the likelihood that you're going to go on to have arthritis or that you're going to go on to injure yourself. These are the things that I think are important. Is there any cure for a lipoma or stop from spending? Okay, so Jay, yeah, like I said before, generally speaking, they're self-limiting, in meaning that they'll expand to a certain size, but then they stop. They don't usually come back. If they keep growing unrestricted, then you need to have that biopsied and checked, because that is the hallmark sign of something that is not benign. It is now cancerous. So there's not really any way to stop a lipoma. Usually, if people have a lipoma and it's causing pressure or pain, pressure on another area, important area, or it's causing significant pain, then we'll take them out. I just did one a couple of weeks ago on a gentleman who was having a lot of pain in his shoulder because of it. And so I removed it. But there's not really any way to prevent it. And the one thing about a lipoma is that if you do excise it, there's a chance that it could come back. So unless it's causing a problem, I don't do anything about it. But if it's causing pressure on an important area or significant pain that is limiting your function, your ability to do things, then I'll do a resection. Let me see, one more here. In one of your videos, you discussed BPC 157 for ligament regrowth is worth a shot for acromioclavicular joint pain. One of my patients complains of pain every winter when he plays badminton. Thank you, sir. So, no, I would not say it's going to be helpful for that. And that person, so they're playing badminton, which is an overhead activity. And if we do a X-ray of that person's AC joint, I'm sure we'll see AC joint arthrosis. And if you do an MRI of their AC joint, you'll be able to see the edema in the distal clavicle and the corner of the acromion there, because they have irritability from that. And usually people who have arthritis or arthrosis, it's going to be worse in the winter. And I'm not entirely sure what's the reasoning behind that. And it may be because of changes in barometric pressure, but it's going to be worse. And that's why we have people who winter in warm places, such as Florida or Arizona or down south Mexico. So that person has the way I would describe it to them is that, you have a structural problem. You have these two bones where there used to be a space, and now the cartilage is worn out, and now they're touching and rubbing, and that causes pain. So BPC 157, PRP, stem cells, all of that stuff is going to do jack shit for that. That's a structural mechanical problem. And so it needs a mechanical solution. And fortunately, although it is surgical, the mechanical solution for that is very simple. And you can do it either open or you can do it arthroscopically. I said today I did 4 shoulders, and for 3 of them, I did a distal clavicle excision arthroscopically. So I did a rotator cuff repair, and then when I came out and finished the rotator cuff repair, the last thing I did was I trimmed off 5 millimeters of the end of the clavicle, so that now there is a space where the 2 bones were rubbing and touching. And because of that, you don't have pain anymore, and especially when they go to do overhead activities. So anybody who's done a lot of manual labor with their arms, a lot of weight training, or a lot of overhead activities, all of those people are going to end up having AC joint arthrosis and arthritis. So you can tell that person BPC 157 is not going to do jack all for that. So they need to really get that fixed. And if they've had this recurrently over several winters, then it's more than likely going to be as a result of AC joint arthrosis. So they need to do that. I said that was going to be my last one. This is going to be my last one because I just saw something that I just wanted to touch on. So Julian says, the weird thing is that the subluxation came 4 months post-op, crossing my arms. I also developed frozen shoulder. No Hill Sachs on MRI, so not entirely sure. I have a follow-up. So here's the deal. You said that you had a tenodesis and an anterior stabilization. So sometimes people have labral injuries on both the front and the back. And the secret of what is wrong is what you just said. And so with the anterior stabilization, the position of death is this, okay? So what we call abdur, or abduction, external rotation. That's the position of death. You put your hand here. If you can't see your thumb, you've gone too far. Oops, your shoulder comes out the front. That is anterior instability. But anytime you do this, cross your arm and it comes out the back, or you have a subluxation, that's posterior instability. So here's the problem, my man. Your surgeon either did not see, either it wasn't present on the MR imaging, and your surgeon didn't look when they went in there as part of their sort of joint inspection, which is the first step of the shoulder arthroscopy. But you have labral pathology at the back that's not fixed. Okay, so you're good out front, but in the back, on the posterior back part of your labrum, or back part of your shoulder joint, your posterior labrum is off. That's why, and the clue to that is that when you cross your arms in front of your body, your shoulder telescopes and goes out the back. So that's what you have going on. So yeah, they fixed the front, and it's not a mystery. It's just that either they missed it, it wasn't present on MRI, so he didn't think to look, and he missed it and didn't, or sometimes some guys don't know how to fix it at the back, man. They're good fixing stuff at the front, but not everybody feels comfortable switching the camera from front to back and then fixing stuff at the back. So that's what's going on with you. You have a labral tear at the back aspect of your glenoid, and that's why. And there would not be a Hill Sachs that's associated with posterior subluxation or dislocation of the shoulder. Well, sometimes you can, but it's not as common. So you didn't just have anterior instability, you had panlabral instability of the shoulder. The front was fixed, but the back was not. So the back still needs to be fixed. So that's what I would be talking to your surgeon about. All right. Well, because my wife is waiting, happy wife, happy life. I can't keep her waiting. And yeah, so it was great chatting with you guys. I'm going to do it again next month. And as always, that's been a word from Dr. Chris, not your everyday ortho, where we see one, do one, teach one, y'all. Have a good night. Thanks for coming out, you guys. You're amazing. Yeah, and let me know in the comments section if you guys think the Patreon is a good idea. I think that's what I'm going to be doing. Anyway, I got to run. Ciao.